welcoming everyone to this webinar, Mental Health Services, Imagining a Better Future. So this is one of a series of 7 Health and Care Futures webinars, which are a part of a programme in activities to mark Turning Point's 60th year. Turning Point has been running for 60 years now, and thank you so much for being here. So my name's Stephen Parker. I am the Head of Service for Mental Health at Turning Point, and I qualified as a psychiatric nurse about 30 years ago, which is obviously a very long time, and it's been a big part of my life, a huge part of my life. I have particular interest in comorbid substance use and mental health, and also the wider determinants of health with specific regard to mental illness. A bit more about Turning Point if you don't know us. So since its founding in 1964, Turning Point has grown year on year, and last year we supported over 197,000 people, which is an awful lot of people, with issues around mental illness, learning disability, substance use, and sexual health. And mental health services that we run include things like talking therapies, or the old IAPT services. So that's talking therapies for people with what we would call common mental health problems, but they are common, but they're not necessarily easy to deal with, but things like depression and anxiety. We have independent hospitals, mental health crisis houses, crisis helplines, outreach services, and supported accommodation. So we operate across a whole gamut of different conditions. And in our 60th year, we reflect on how much society and health and the social care landscape has changed. We also want to look to the future, and these webinar series is designed to examine some of the big challenges facing the sector. And there are numerous challenges now facing the mental health sector. Whilst mental health services are expanding, demand for services growing at an even faster pace. It's really difficult to be able to personify that, or just to show you that, to illustrate that in any real way. But just a small example, there were surveys done in 2019 and 2020 that showed about 10% of people felt like they suffered from a depressive disorder. But this rose, over doubled to 21% in 2021. It's fallen again to 17%, but that's still almost double the amount of people who feel that they suffer from something around depression, which needs treatment. And it's significantly more than only just 7 or 8 years ago. A lot of this can be attributed to the environment that we live in. So, for example, the pandemic that we came through, the cost of living crisis. But I think we've also seen a huge increase in the awareness of mental health issues. And I think also people are feeling less stigmatized than before, and are much more likely to identify as someone with a condition. However, only about a third of the people who identify as having a condition are actually seeking help from it. But stigma remains a massive issue in accessing mental health services, and ethnicity data shows a stark disparities in inequities in mental health, most notably for Black people in both adults and children's mental health services. I'd also suggest that a high level of stigma remains for people suffering from any severe mental illness. Additionally, there's growing disconnect between health and social care in spite of integrated health systems, with insufficient capacity in adult social care continuing to contribute to delays in discharging people from hospital. And I could go on and on about the challenges facing the mental health sector, but you're not here to listen to me. I'm delighted to discuss this important issue. We have 3 fantastic people. Isaac Samuels. Isaac's a member of the National Co-Production and Advisory Group, Think Local Act Personal, or TLAP, and is co-chair of the working group for the All-Party Parliamentary Group on Adult Social Care. Isaac's a passionate advocate for self-directed support and supporting people to retell their narratives in a way that makes them stronger. We're also joined by Peter Devlin, who's the Director of Adult Services at Essex County Council and is the Mental Health Policy Lead at ADAS. Peter also remains a practicing approved mental health professional. And also, we're joined by Turning Point's Alicia Lempicki, who's a locality manager at Turning Point, responsible for a number of services across Nottingham, including crisis and transition services, accommodation for complex support needs, and also community-based services. Alicia has a background in social work and has worked at Turning Point for over 8 years. So I'm going to ask each of the panelists to make some opening remarks. I'll then take the chair's prerogative to ask some questions, and there'll be an opportunity for questions from the floor. So the way this is going to work as we proceed, if you have any questions and comments, please add them to the Q&A. I can see some people are doing that already. There's a Q&A symbol at the top of the screen. Click on that and you can ask your question at the top of the screen. Please say who you are and where you're from, and you can also respond to other people's questions and comments. You won't actually be able to ask the question yourself because this webinar format doesn't allow for it, but I'll keep an eye on the questions and ask them on your behalf when we get to the discussion. So now to our panel. Can and should charities and social enterprises play a bigger role in the delivery of public services? And we'll start with Isaac, please.
Yeah, so hi everyone, so I'm Isaac. I have had severe and enduring mental health challenges for over 25 years. I think, Stephen, some of the things that you started talking about really resonated with me around the stigma that we or people like me still experience when trying to access mental health services. So knowing that I'm quite a gobby person and how much I can fight to kind of get the support I need, is often at a point where it's probably too late. So what tends to happen for people like myself is that we're in moments of crisis, we're unable to get that really early intervention support, and then we end up in places that really have a lot of restrictive kind of practice. And I'm not saying by any means people like me shouldn't end up being sectioned. I needed to be sectioned in my life for my own safety, for my own well-being, but actually there was a lot of things that could have happened before that. I think sometimes when we talk about mental health, we might focus on, particularly nowadays, a very generic kind of population-based kind of mental health, and I'm really interested in focusing on those with the most severe needs. And where I've found my support has been in the voluntary and community sector that has been much more safer, much more kind of proactive, and a space where I've been able to test out some of kind of the things that I need. So I think it plays a vital role, but I also know that actually community mental health services, the NHS, everyone plays a role in supporting people to have good lives and support their mental health. I think we need to have those kind of conversations about how do we make sense of mental health in the context of it being socially constructed. How does society play a role in providing support for people like me? Yeah, so I don't know if any of my other panelists would like to respond.
I'm very happy to ask a question around if you could say a little bit more about the barriers to care when you most needed it. It just seems a little bit of a weird juxtaposition between needing help and not being able to get it.
Yeah, so I always talk about it, and I'm going to talk about it, and if I use clumsy words, please do forgive me. So when you are unwell, you necessarily don't know you're unwell. It might have got to a point where you cannot see the world as you once saw it. So to seek help in those times is very, very difficult. And there is a level of being able to navigate complex systems that requires you to have an ability that you probably don't have, or I haven't had when I've been unwell. Often it's meant that family members, people that love me, have had to step in to do some of that stuff that's had a detrimental impact on our relationships. I often feel that the threshold or the bar is so high that when people come into services, that acute mental health services, they end up staying there a lot longer. Often the very things that we would expect from those services don't necessarily happen. So thinking about being acutely unwell, you would want to go to a place, receive really good support. Wards are very chaotic by their nature. There's a lot of kind of different members of staff. There's often different ways of providing that support. I'm not sure mental health acute services are the best place to go and get well, but they're the only solution that we have currently. I think a lot can be done in terms of early intervention. I think there's a lot around prevention. I certainly would say that we have come a very long way. Some of the biggest barriers, particularly for those that have severe enduring mental health, might be their previous experiences. I come from a racialized background where we don't talk about mental health. It is a very taboo subject. There is a lot of mistrust that we have been told by our elders and our family members because of their own experiences. When we do go out and we seek help and support, there, I suppose, is very white-centric, Eurocentric kind of support offers that don't necessarily meet our needs. But I think we've come a long way. So I wanted to just highlight a really good example of kind of some work that happened. And I know colleagues from Greenwich will be here, Lee Goddard, and so around developing a mental health pathway or a mental health system that really speaks to lived experience. And when we talk about lived experience, we're not a monolith or a homogenous group of people. We have very different needs. Mental health, for me, is around how does a community respond to those that need help at a particular time? What is the infrastructure we need around health, social care? It's not just those things, it's beyond that. What role does the voluntary sector, what role does families play? And I think developing through co-production, like community-based kind of strategies and processes and pathways, I think we can serve people better, because what we don't want is people like me that started my journey 20 something years ago, still accessing mental health services. What we want is people, when they're in crisis, to get the support they need in a timely manner, then to start to rebuild their lives, being management. Things that often get celebrated for about people like me having a job, having a relationship, having a home, are just common things that my peers experience, but they seem to be very out of reach if you have a dual diagnosis, if you have mental health challenges, if you are black or brown. And what I wanted to just say is when you start to talk about all of those services that Turning Point provides, I was delighted to be invited because I've been someone that's accessed all of those but throughout my life, and they have saved my life. They've enabled me to get to a place now that I don't necessarily need the support that I once did, but it's been a journey. And if we could really think about people in a holistic way and we could support people to get that support when they needed it, maybe people won't spend 25 years getting there, spent 25 years getting there.
No, thank you. That's really insightful, and I think there's something really important about the message around timely help when the people need it, and then not forcing it down people's throats when they kind of don't. So yeah, I've absolutely take something from that. I'd like to move on to Pete now, if I can. I don't know if you've got something prepared you like to talk about, Pete.
Yeah. I mean, I think just to share some reflections. I think credit to it's always nice to follow Isaac. Isaac, I think you're such an eloquent speaker, and it's I'm always inspired to hear your story and about the things that have mattered and made a difference to you along your journey. And I think, having listened to you speak a few times about the people that kind of gave you hope when you were struggling to find hope, it was often the people that took the time to really listen. They took the time to genuinely want to understand what mattered to you, that wanted to speak about what your hopes and ambitions were for the future. And I think that kind of strikes the chord with one of the points that you made about mental health being seen as a societal issue and not an NHS issue in the first instance, and the importance of us recognizing that we are all human, and that a range of circumstances that sit around us will have an impact on our mental health. And we talk about the social determinants of health, and it kind of brings me back to understanding mental health in through the lens of population health management. And what's very stark in that, when you look at the number of years that people will live and the quality of life that they will have in the years that they live, the thing, what's important actually is lifestyle. How you choose to live has a big impact on how long you live and how long you live in good health. About 40% impact. Where you live, the housing, social relationships, your financial position, your purpose, i.e. employment or other, all have, together probably constitute about 80% of how long you're likely to live as an influencer, how long you're likely to live, and the quality of life that you will have in the years that you live. About 20% relates to health, your relationship with health, and the interventions and treatment that you receive from health. So that kind of puts in place sometimes mental health, because I think sometimes when we think about mental health, we think about the NHS, and I suppose I would be here to say it's much bigger than that. And actually the NHS is only a small part of that. And that as individuals and as people in a community that works with individuals that might be impacted by their mental health, and possibly with dual diagnosis and other conditions, that the impact that we can have is probably likely to be greater than the impact that clinical interventions will have. A person seeing a GP or a health professional for a very limited period of time each week. The relationships that we have are likely to be more enduring and ongoing. And sometimes we might have more time to be able to listen and be able to really listen and hear and ask questions that support people to move on or to think about what their ambitions are for life, and sometimes to be able to get alongside people and to hold the hope when they're struggling to hold the hope themselves. So I was really grateful to be asked by Turning Point to come today to talk, because actually I suspect for a lot of our colleagues on the call today, many of them will be individuals that are working directly with people who are affected by mental health and substance misuse. And I can't say enough about the importance of the roles that you play on a day-to-day basis and through your interactions with people, no matter how big or small they are. So please hear that. I also wanted to say a little bit about again, through recognizing that healthcare is only one element of, what supports people living well and the medicine of life. What I wanted to say is that, for lots of the people that we work with, there has been an over reliance on diagnosis, and diagnosis as being sometimes a means to access services. And I think that diagnosis has a place and is important, but again, it's not the only thing that should be considered in the way that our services are organized. And in fact, I don't think it should be the primary thing which is considered. I think it's about holistic needs-led care. So what is it that people need in order for them to live well, and how do we enable that? The environment around them to be conducive to supporting their recovery, to living well in the first place. And for those with serious and long-term disabling mental health conditions, how we make sure that we also ensure that they have the rights, protections, care and treatment that they require. So I'm here to say that we need to see mental health as a holistic and a population-based thing. We need to focus on needs, and we also need to create the conditions for people to exercise agency and control over their own lives. And diagnosis, for me, there's always a tension between this idea, and I'm sure that you will all be with me here on, that that medical professionals or professionals diagnose people, and then, you know, the power differential straight away is, you know, you come to me with a set of problems and I tell you why you have those problems and how that problem sits with the diagnosis, and then we give you treatment. I want to go back to some of the stuff, Isaac, that you've continued to emphasize when we spoke about the importance of listening to individuals, co-creating, co-producing plans, asking, you know, supporting individuals to determine what circumstances and support they need around them in order for them to thrive at any given point. You know, and I think that forms the basis of what we need. So I'm advocating that we move away from diagnosis, place less reliance on it, see it in the context of being one aspect of things, turning to people and hearing their voices, genuinely, truly listening, being present, co-producing things, thinking about societal needs, us as needs as human beings. And for some of us that have been in this work for a long time, you know, Maslow's hierarchy of needs, really bringing that some of those concepts into this. And Stephen, I see that you're smiling there. I'm sure that was probably part of your training as well.
Absolutely.
Yeah, and I think we should remind ourselves that for lots of the people that we're working with, the health and care structures and some of the societal structures that sort of go beyond that are actually structures which poorly serve the individuals with the most complex needs, and where they have a range of different diagnostic profiles, because services tend to exclude on that basis. So lots of the individuals that we are working with are individuals that are most marginalized, most excluded, fall through you know, pathways and structures and thresholds and what have you. And as a consequence of that, sadly, they live less years, and sometimes they live more years in poor health. You know, so there's a lot of inequality there. So we, as supporters of individuals that are working with that, need to be also the advocates and the champions, and the challenge sometimes to the systems that discriminate for individuals and particular groups. And I think, you know, as Steve, you spoke about people from black and ethnic groups and other groups that are seldom heard, who again are further negatively impacted. I just want to say a little bit about, because this is a reimagining piece as well for me, around, you know, what would a future mental health system look like? So I think as a principle, I would go to kind of parity of esteem, and say that actually, whilst the prevalence of mental health conditions has gone up over the years, the investment actually in health services has largely gone into old age and frailty. And lots of the policy has been around how do we manage the emergency departments and the acute hospitals, and that's very, very important. But we've fallen behind in mental health and substance misuse services, and there is no fair share in relation to the finance and the investment that goes into our services to support the people that we need to. And when I talk about our services and the people that we support, I speak not as an NHS organisation, but as a community of support workers and people who work with people who have mental health conditions, you know, at whatever level. Community-owned organisations, not-for-profit organisations, social care, our care providers in this space. So we need to see more money coming into the system and the right flow. We need to be normalising mental health, and we need to be making sure that actually that we support all of our health professionals to understand that mental health is part of everyone's job, and that we should all be bold and courageous in being able to ask people how they feel, recognizing that lots of people with other disabilities will also have mental health conditions. So let's stop boxing it. Let's have the conversations. Let's equip staff with the awareness, with the expertise, and with the confidence to be able to support individuals with their mental health and well-being. And let's make sure that national policy, including policies around education and exclusion and what have you, recognise mental health and recognise individuals that are likely to be marginalised. You know, how can it be right that somebody's detained under the Mental Health Act and evicted from their property when they haven't got the mental capacity? So our national social policy also needs to change. We want to see changes in those areas, and I would like to lobby, you know, at every level, at an individual level, and also, you know, through the social structures that we're in, to be able to rebalance some of that focus, resource, money, but also attention. So I think, Steve, I've probably taken my time up there, but I really appreciate
but you're
your offer.
fascinating, so that's fine. We said we'd be loose about this, so yeah, no, that's fascinating. Thank you. Without further ado, let's move on to Alicia.
Thanks, Stephen. So yeah, I suppose I've got some reflections on what both Pete and Isaac have said, and also as Pete mentioned, about thinking about, imagining that better future. And I think to imagine a better future, really, we need to look to change some of the narrative that we use. I think as we've moved towards more integrated care systems, I think what they have done is further highlight some of the stops and the gaps within the system. And I think for a lot of us working in that system, it can sometimes feel like we're having the same conversations, albeit at times they can be quite uncomfortable conversations. But I think particularly thinking, our role in Turning Point as a VCSE organisation, I think we play a really important role in bridging some of those gaps between statutory authorities and local communities, and whether that's through us delivering services that help to plug those gaps, being part of provider networks and alliances. But I think probably most importantly that we are highlighting the experiences of the people that we're supporting. I would say, from my experience working within the mental health sector over the last 10 years, it is really evident that the fragments within the system impact probably the most marginalised and seldom heard voices. But it does feel like at times that there is more of an approach to having conversations about people without them sort of necessarily knowing those conversations are taking place. And I think language can play a big part in this, and the way that we use it. We use words such as risk and assessment, treatment and pathways. And I think these discussions often lead to people being placed onto pathways, but that doesn't really evidence that that person was met where they are currently on their journey. And so it begs the question of how well have we really listened, how well has people really listened to that individual and what it is that they need. I think words can be really impactful if they're used in the right way. And in other ways, they can be more barriers to getting the right help at the right time. And if language is used within the system that's excluding and stigmatizing, we can only wonder how that translates to the people seeking support. I have recently been part of forums locally where we look at system-wide approaches to transforming pathways of care. And there is a real drive amongst the system to be, more radical in that approach to transformation. When we think about the ideas of step care approaches and how they better support knowledge as services and pathways of care. But really my view is that currently there are many, many doors in the mental health system, and some of these doors can take a long time to open. Some of the gaps between one door and another are too big. And to be honest, sometimes the doors don't always look very inviting. So for me, things such as the no one door approach is a really great vision and should be an ambition for all of us in the health and social care sector. But to really think about the future, I think there has to be the means to think beyond, the constraints and the challenges that we're currently having, such as a lack of resources, high thresholds and a demand and capacity challenges. I think what we need to really think about is what is a healthy functioning mental health system? What does it look like and what does it feel like? And I think that includes reiterating the message that things like the no wrong door approach is about trying to simplify the system, and doing that by improving access to services, thinking about early intervention and prevention, and as people have rightly said, about that whole person approach to care as well. And I think really we can only approach this, and this approach can only really be fully realised if we adopt early the principles of co-production as an absolute in any transformational work. And I think we all have a part to play to ensure that the power is shifted to those who can provide the insight and the experience. So for me, when I think about, imagining the future for mental health, I think it's about those doors, going back to those doors and having doors that are easily opened and are embedded in local communities. I think services that can easily support transition from one service to another without the need of further assessments and retelling of stories, which can often happen. I think doors that are viewing the whole person, and we're not just turning people away because of one complexity or one need that outweighs another, but actually having more of a culture of collaborative working and reasonable adjustments. Doors that talk to each other, where services are really truly talking to each other and have those levels of communication. And that helps all system partners have a better understanding of what the provision of support is, having local expertise in all domains, whether that be clinical or non-clinical, and experts by experience, but all with that sort of team effort mentality. And really having that choice available for those who are trying to navigate the system. I think it's really important that those doors have a promotion of inclusivity, and that's through culture, that's through practice and language, and policy and process as well. I think, as previously mentioned, the thresholds, it is a bit of a crisis situation in a lot of services. So how can we have services that are able to anticipate need instead of just responding to those crises? And I think really lastly for me, it's about seeing a future where we aren't just advocating for the people we're supporting in our communities, but that we have an established system that provides more and more spaces for people to be able to advocate for themselves.
That's fantastic. Thank you very much. So now it's time for some questions, and rather than me asking a bunch, I'm just going to start off with one because we've got quite a lot of questions, but I'd like this to be a conversation. So if people have got questions for each other as well, let's do that. But I'm going to kick off a question that I formulated through Pete's talk, just around the idea of, you were talking about patient choice and person directed care, and absolutely laudable. I'm just playing devil's advocate a bit. How do those things, how do they align with the Mental Health Act and deprivation of liberty and the kind of the seedy underbelly of mental health care?
That's a really good question, actually. And I mean, I think for me, it's I think it's always about balancing the rights of individuals against the protections, actually, of the protections required for the individual, and sometimes more widely for the state. So I think at the kind of the sharp end, you've got the Human Rights Act, and then you've got the Mental Health Act, and you've got to be very balanced in the way that you recognise that. I would talk as an approved mental health professional about the sort of principle of reciprocity as well, which is that whatever control you exert over somebody, the benefit that they stand to gain has to be greater. So actually, there is that. But I would also say, and I'd go back to some of my earlier points, Steve, about it's the little things that matter. Actually, in your interactions with somebody, you can be carrying out Mental Health Act assessments, but you can still support people to exercise control. You can still listen carefully. You can still operate respectfully. In the way that you undertake things, so that kind of personalized approach to things, and the kind of the importance that you have and your mindfulness of being able to work within the responsibilities of the job that you have to do, but to do that in a way that's person-centered feels very, very, very important to me. I mean, and through my career, I mean, I started as an ASW back in 1998, you know, so quite a lot of years ago. I qualified as a social worker before that. But, you know, I mean, we would do things like, you know, arrange for people's parents or their loved ones to join with them and go in the ambulance together if they were having to go in hospital. You know, I've seen an ambulance, bless them, stop at a tobacconist to get somebody cigarettes on the way to hospital because the cigarettes was such a preoccupation for somebody. You know, so I mean, I'm using those examples as an illustration of trying to be flexible, but at the same time making sure you know, that we're doing the right thing by individuals as well. So I think you can try and be person-centered even in those circumstances, Steve. I hope that that's helpful.
No, it absolutely is, and it's something I was hoping you'd say. Isaac, I don't know if I can bring you into the conversation about that, because you're obviously someone who's experienced this firsthand, and I don't know if you have got any words.
Oh, big question. So I think legislation is really important because at its heart, we know legislation isn't perfect. And we know there is a need to constantly review and reform legislation. But what we know is that that forms the way that people might operate within. And for me, when a social worker, an approved mental health social worker, is doing that assessment, if they're really holding legislation in mind around how do they do or have the least restrictive practice is really important. And if that wasn't there, I think there would probably be much more restrictive practice than there is. I think we've moved into a space where people are thinking about alternatives than just admission to hospital. How do we ensure that people have a voice even when they're really unwell? So I'm not saying it's perfect, but what I'm saying is that we've come a really long way. And the more we start to think about centralising the lived and living experience of people, including the workforce of people that are making decisions in really difficult moments about how they support people to navigate the worst day of their lives, and those small things, you know, those conversations, those things around, have you thought about this? Suggesting to your colleagues, is there an alternative? Is there a crisis cafe? Is there maybe some home treatment? Is there a way that we can maybe mitigate some of this risk? Is there risk appetite? All of those things I think are really important when we think about mental health being a really dynamic kind of approach. So I'm not sure that I answered your question, but what I would say is that I have seen over my own journey, and Pete, we probably go neck and neck in our journeys in mental health. Like 1997, I think there was less of that kind of stuff. Now I think we just expect it, and we have much more emphasis on putting the person first, much more emphasis on families, much more emphasis on keeping people where they live, much more emphasis on the least restrictive practice. And I think that will continue to grow, and we need professionals, people with lived experience to really champion that kind of way of supporting people around their mental health.
I completely agree. I've got a small anecdote. When I started my nurse training in 1992, I went on a ward, and it was one of the old bins just outside London, and they used to put everyone's clothes in the same washing machine. So everyone would wear each other's pants because it was easy. And yeah, that would be absolutely unheard of now. And, you know, it's frankly disgusting, but it was completely normal, completely normalised. So I'm just, with that, I hope we sort of show how far we've come, yet there is still, as people are talking about, so far to go. So I want to kind of concentrate for the last sort of 20 minutes of this on the future and the better future, which is what this is about. And there's a question from Ivan in the chat, which talks about the government seeing community and social care as a key to fixing the NHS. So how might the social model of care better address the complexities of mental health compared to the medical model? Pete's already mentioned a bit about that, so it's something I'm going to pass over to Alicia, sorry to put you on the spot. But how can the future of social care address the complexities of mental health better, or as well as, or in a completely different way than the medical model?
So I think that, you know, thinking about that social model pertains itself better to that whole care approach, you know, which is often what we've sort of reflected on, is that you know, mental health or challenges with mental health might be one part of somebody's identity, and there is much more that goes into somebody living a healthy, meaningful life. And part of that is, as Peter mentioned, around, you know, hierarchies of need, people having access to quality housing, to the right money to be able to sustain themselves, etc. And unless we as a system talk to each other, and to look at how we reduce barriers together, it becomes very difficult. It's difficult to, when we compartmentalize people's needs, to be able to tackle them. So I think being able to provide better access to services quicker, you know, having worked within a step down service where, you know, people are discharged off wards without having safe and appropriate accommodation in place, without having their sort of finances properly looked at and support given and signposted to places that are able to support them. I think it's really difficult. And, you know, a lot of what we do around, you know, working in mental health and within Turning Point and other VCSE organisations I've worked with, you know, it's about having that really value-driven focus on what we do. And to do that, it's looking outside of diagnoses, and it's looking at people's experiences, and thinking about what it is that person needs, and then being the expert in that. Hopefully that answered in a roundabout way.
Absolutely. I don't know if Isaac or Pete want to come in, or we'll move on to another question. Pete.
I will come in. I mean, because I think there are lots of there's kind of lots of angles to this, isn't there, around how do we, you know, I think we've kind of created a movement here in relation to linking mental health, situating it in a societal context. I think we're recognizing that kind of the socioeconomic environment has a significant impact. So deprivation and poverty has a massive impact on mental health. So unless we start to address those issues, mental health is likely to continue to deteriorate in those areas. You know, so if we think about the government's drive towards employment and economic activity and, you know, inactivity and what have you, then I think, you know, actually with an aging population, we need our adult population to be fit and well and able to contribute work-wise to the employment requirements that we've got. So I think there's that aspect. I think for me, there's the aspect of, you know, if we think about the challenges that the health service is under at the moment, if we don't do something which is interventionist, the extent to which it builds pressure into the system, further pressure. So I think there is that issue. Then I think fundamentally for me, there is the kind of moral and ethical imperative that we have, which stands above everything. And, you know, and I, you know, as being somebody who's worked in mental health services for so many years, you know, I fiercely believe that our people with mental health conditions are entitled to the same access and equality of service as anybody else. You know, so if you're suffering with a mental health crisis or you're suffering with an acute medical condition, you should expect a good level of service. You know, so, and I think that again is something that you know that we should be lobbying on. And I think we should also notice that, you know, kind of, for example, you know, the mental health and well-being of our young people, and the relationship between, you know, mental illness in childhood and the long-term impact that has, you know, so the importance of attending to that, as well as educational attainment, you know, and all of those things. So I think what we've got to get better at doing is making the connection between mental health, mental well-being, and actually society. And building, you know, not only moral and ethical arguments, but also economic ones. You know, and I think that's you know, that would be where I suggest we make that, and to make the connection for the different ministerial departments, be, you know, in relation to how those things interact with one another.
Well, thank you. Isaac, do you want to come in, or should we go on to another question?
Yeah, I'll just quickly say that I think if you got a group of people that have mental health challenges together, what they wouldn't do is build a bricks and mortar approach to mental health support. They would talk about community, a sense of belonging, all of stuff that we've talked about. So I think mental health is everybody's responsibility, or supporting those with mental health challenges, and that will feel and look very different in different places. And I think we need to really think about how we centre like a community approach. And the medical model plays its part, the social model, but actually the human model, which is about us and society really stepping up and stepping in.
Yeah, no, I agree. It's definitely plays its part, but it's tended to be the major player in town for years and years, and yeah, hopefully this is a change. And there's a question here. Just need to see who it's from. Philippa, who at the end of some examples of good practice, she asks, is the mental health review a moment in time when we could embed prevention and early intervention into the system? We haven't really spoken about early intervention, and for those of you who don't know early intervention, the NHS took the moniker for people with early onset psychosis, and it was a wraparound service for very young people. But I guess for the purposes of this conversation, it could be used to think about all sorts of different early intervention. So is the mental health review that's going on in government at the moment now the point where we can start to embed prevention and early intervention into the system? Pete?
Absolutely. Absolutely, because, you know, and I mean, Isaac's touched on this, and so has Alicia, but, you know, there will be more people in hospital if the community services are impoverished. You know, it's as simple as that. You know, you have a more diverse and more responsive range of community supports and services. You will be able to support more people. Less people will become unwell to the extent that they require admission to hospital, and more people will be able to, you know, be supported when they are unwell outside of hospital and outside and in lesser restrictive environments. So if we look at some of the changes to the mental health reform, that, you know, the mental health bill, I mean, one of them namely would be changes in criteria. So actually a higher threshold for detaining people, and rightly so. Again, going back to balancing the people's human rights against the protections and the restrictions that are imposed when people are detained. Also, clearly, they've made it clear that there is a move away from people with learning disabilities and autism being detained under a Section 3 of the Mental Health Act treatment order. If the purposes of their admission is to meet their neurodiversity or learning disability need, so where there isn't a clear treatment purpose for a mental health condition. And of course, they're looking at extending increased rights to advocacy and protections within the mental health bill. So, and I know that the Department of Health and Social Care with government are looking at what the impact of the mental health reforms might be, and what would need to be in place to support a reduction in people requiring hospital and requiring detention under the Mental Health Act. So I think there's a golden opportunity actually. Now, you know, as this bill, you know, we've been told in the King's Speech that the bill is coming through Parliament in this session, which is this autumn. And then obviously the work will be done with the Treasury in relation to, well, what's the cost of any changes that will be made? And it will also follow through in secondary code of practice guidance and what have you, which will tell us how we should be working. So I think there is a real opportunity for us to lobby hard now for making sure that we get the right community mental health provision and investment to move away from hospital as being the solution when people become unwell.
Thank you. Anything to add, Alicia or Isaac? around prevention and early intervention?
Just a bit of a reflection from me, really. I think there has been a real increase in sort of self-help or self-management as a modality, particularly as we've kind of advanced as into a more of a digital world, thinking about sort of apps and resources. And I think technology used to support self-help and self-care can be a really wonderful way to kind of promote more choice and control in accessing earlier support for somebody's mental health. I think particularly when we're looking at more holistic approaches to well-being, but I think that we have to be careful to consider it in a way that it doesn't, or we describe it in a way that it doesn't replace the need for other avenues of support, or as a free resource to those commissioning services. So I think it really does need to have the investment required to ensure that it's successful as an early or preventative intervention. So I think really, we can consider using self-supported self-management as a way to remind people, one, that they're not alone on their journey, but also that there are services side by side.
Thank you. Isaac?
So I think we've learnt a lot about how legislation is interpreted. And I think it's fair to say the Care Act had lots of emphasis on wellbeing, delay and prevention. And I do agree with Pete that we've advocated for this for years and years and years. So I'm very hopeful, not without skepticism. There is a lot to be done. But if we can prevent people like myself spending 25 years accessing mental health services, that is not only good for me, that is good for the whole of society. And I hate to talk about the cost benefit for systems. There isn't any more money to be had, so we have to do things differently. And if we can prevent people coming into services and being traumatized, and actually not living the lives that they want with purpose and meaning, I think that's a win-win for everyone. We will continue to advocate for it. I hope that we can have the infrastructure to support it. And I think there are very different ways that we expect to receive support nowadays. So we have peer support, we have digital, we have many different ways that we can support people to navigate their mental health challenges. And I think for me, never losing sight of this is a journey, and we've come a long way, and we will continue to advocate for it.
No, thank you. Just by time for one more question, I think. I want to go right back to the first question that was asked, because I think when I'm thinking about services and stuff, I always think about the monitoring of them. And an early question from Jackie was around, how do you know if services are doing the right thing? So how do we monitor such, it's really easy to monitor stuff like broken legs getting better, but how do you monitor a person-centered approach?
Is that from my friend Jackie Darlington?
Yes.
So Jackie, wonderful question. So the way that I think we do it is we do it as a community of interest, right? We are all interested in mental well-being of our citizens, and there's a role for people with lived experience, there's a role for organisations, there's a role for everybody in that, but it has to be triangulated, and that's probably a really wonky word. But for me, like, how do you involve lived experience, evaluation, monitoring of services? Because we know it, we live it, we breathe it, and applying like that quality improvement lens. So there's no point saying to somebody, what's your experience, and nothing happens with that. We have to take that information and improve our service offers.
Thank you. Others? Pete?
I mean, Alicia might want to say some stuff, so I'll leave some space. But I think it's you ask people. I know that sounds like, actually, what was your experience of the service? Are there things that we could have done differently? Is this working for you? Do you feel involved? I think some of those at a very, very basic level are the beginnings of being able to understand whether what you're doing is really having a positive impact on people. And then I think you can aggregate that up and we can look at different surveys, but I think, we are public servants and we're here to serve the people that we're working with and to get alongside them. So that would be the basis for that I would start from every time.
Oh, thanks, Pete. Alicia, I don't know if you want to come in.
Yeah, thank you. So I think, as I mentioned earlier, I think when we talk about the implementation or transformation of services, as I said, I think the earlier that we adopt the principles of co-production, of that being an absolutely sort of underpin of everything that we do, I think until we do that, it's very difficult to know the success of what we're doing, because quite often it can be easy to bring people along at the end of a journey. We've done this, we've set this up, what do you think about it? But ultimately that consultation, co-design, and really asking people from that very get-go of what does it look like, what does it feel like? I think the earlier that we adopt those principles, the more likely success we have in getting good outcomes for people, but also getting people engaged within that journey.
Okay, thank you. Well, we need to start wrapping up now. We've got 3 minutes left, and I'm really sorry to people who asked questions that we couldn't get to. Kind of wanted to maintain the narrative about imagining a better future. It was quite all been impossible to ask every single question. But what I really liked is that some people have been answering the questions, both to each other and to the questions that have been posed to the panel. So I think that's really good, and I'm gonna try and read those things a little bit later and take something from them. But I wonder if, just by way of conclusion, you could each take one point that you'd like people to walk away with after the end of this webinar. So what one thing in conclusion would you like to leave people with? I don't know. I'm not going to say who needs to go first because that's unfair. But if one of you could go first, it would be great.
I'll jump in then. So every conversation is a conversation about mental health and well-being. So wherever you find yourself as someone with lived experience on your journey, like, I think every conversation has to be centered around that. So no opportunities missed.
Thanks, Isaac.
I'll go next, shall I? So I think my last remark really would be about, as I said earlier, imagining that future where we have more and more spaces for people to advocate for themselves about the care and the services that they should receive. And I think, that's a system-wide approach that we should have for individuals and communities to be able to do that.
Thanks, Alicia. That leaves you, Pete, I'm afraid.
I think for me, it's about, I think it's recognizing the power of every conversation that we have and bringing kindness, compassion, and hope, actually. I think, that's what I would say. It's, I think that would probably be where I am. I think most of the magic happens in trusted relationships, actually. I think that's the biggest and probably the most powerful treatment that people would have. I hear people day in, day out talk about special moments.
Yeah. It's going to be similar to what I said, but what I'm taking away from this, and I guess I continue to take away from my work, is it's the small things that make the biggest difference. You can have all the great ideas in the world, but if you don't have human connection, empathy, trust, all those basic things that you're taught at college, I think should be taught at school. If you don't have those things, all the great plans and all the money in the world is not going to make a blind bit of difference. It's about human connection and human interaction that makes all the difference. And if we understand that, then maybe there will be a better future to mental health services. Do you see, like, the way I segued into the title at the end? That was me trying to be clever. So just thought I'd say thank you to Alicia, Isaac and Pete. I think it's been a scintillating conversation. I've really enjoyed it. I hope people listening in have enjoyed it, and thank you for your input as well. So I'd like to close this webinar, and thanks everyone for attending.
Thank you, everyone.
Thanks, everyone.